We switch immediately to the next session, and Jan, this is a session where we are very proud of. I mean, late breaking news from Asian Pacific. Also to have a quite important Asian Pacific delegation here in Paris is really a great honor for us.
Yes, it's very important because we want to share what happened in this Asia-Pacific zone with European colleagues, just to know what is the trend, what are the trends in this zone in terms of treatment, and so it's very important to share.
Yes, so because I know Andrew is a little bit in a hurry to go to Charles de Gaulle and catch his flight, so we're not going to longer stress you up.
No.
And tell us something shortly in a nutshell about the preclinical and clinical research regulations in New Zealand. Andrew, please.
Thanks very much, and thanks to you and to Jan and the rest of the PVI team for the opportunity to be here. And I guess this just gives us an opportunity to explain why you may see a lot of first-in-human results, and you'll often see a New Zealand flag there, and that's because we've done a lot of the trials that really influence endovascular treatment. Now we do them in Auckland, which is a large tertiary hospital attached to the university, and we have a regulatory environment in New Zealand which is rigorous but very efficient to get trials through. And my interest really in vascular device trials really started when I was in Paris, actually, many years ago, looking at the first described use of embolic filters. And I thought, why couldn't we use those in renal arteries as well? So we pioneered that procedure, and it resulted in some publications. And while renal artery revascularization isn't widely practiced now, it did enable us to start setting up a research group, and we've done over 120 first-in-human or early human vascular trials. Currently, for example, we're currently involved in 25 trials of various stages. We have 6 full-time research coordinators, and in terms of involvement in trials and our output, we're in the top 5 centers of the world. And we really focus on those early trial human safety trials. So we're never going to compete with some of our colleagues in the US and Europe with very large post-approval studies. Our sweet spot is early trials. And over the years, we've done trials in peripheral arteries, peripheral veins, and also in the aorta. I get asked, what's the most influential trials you've been involved in? And I remember going to a meeting, Viva, some years ago, and in a side room got shown this little short 2-centimeter balloon, and could I do the first-in-human trial with this? And that patient that you see there is the first patient ever in the world to be treated with shockwave, and you'll see the New Zealand flag there. We're involved in the first trials, and we're also involved in the pivotal trial that little startup company about 12 to 13 years ago got sold for $13 billion. You can see what can happen. This is just the kind of what we're currently doing in terms of trials here, and you can see some very exciting trials that you will have already been aware of is all happening in New Zealand. What about preclinical research? Well, usually companies come to us in New Zealand having already done a lot of that work, that bench work and the animal models and cadaveric models. But in fact, we often do that in New Zealand as well, where I'm attached. Auckland University has full preclinical and animal laboratories, and we often do large animal studies. Just for your information, the reason that I mentioned before, it's not as if the research is easy, but it is very time efficient. So we have 4 ethics committees around the country. They meet every month, so we can choose one of those at any time. Those ethics committees focus on patient information sheets and consent forms, and then we have a local hospital approval that focuses and meets monthly and really focuses on the budget and the legal requirements. So it's a rigorous process, but it's very time efficient, and it means that by the time we get the documentation to submit, within 6 weeks we can be recruiting patients to a first-in-human trial. And that is obviously outstanding. Here's an example. We got approached by Boston Scientific. That's the ethics approval to do the first trial. This is the first patient in the world to ever receive an alluvia. Of course, that made big news. And then we got into the imperial randomized control trial. Again, that's the first patient in the world to be in the imperial trial. And that again became big news. And just a week or so ago, a new device for active aneurysm sac management that I deployed. That's the first of a device called the Signum from LifeSeal. So being deployed to prevent type 2 endoleak, and the rest of the procedure was performed successfully with a great result. And so that made, obviously, the media. So this is an interesting way to look at the world. It's the way we like to look at it in New Zealand, at the top rather than at the bottom of the world. Our sweet spot has been early human trials. And as I say, we have an efficient process that allows us to get those trials done. Thanks, Koen.
Fantastic. Thank you very much, Andrew. Time for one short question.
Yes, we have more and more some issue in Europe about ethics when you perform preclinical study using animals. Or do you see that in terms of twins, for example, numerical twins? Do you see any evolution about this?
Yeah, I think there's more and more. I think in time and in my experience over the last 10 years, there's been less and less reliance on animal models, and even so computer-assisted modeling, I think, is going to replace that. AI-assisted will mean that, in fact, the cadaveric and the animal model requirements are far reduced. So I think we're in a new era that AI is going to really help us with that.
Thank you so much.
Okay, thanks.
Have a good flight.
Yeah,
safe flight.
Safe and relaxing flight. Thank you for coming.
You.
So Jan, so we move to the second speaker from Singapore all the way, Terence Theo Kiat Beng. I don't know if I'm pronouncing perfectly, but I do my best.
Thank you very much. It is correct, but only a Chinese will understand that the surname is right in the middle.
Okay.
All right, thanks.
The DVT Singaporean experience, please.
Thank you. Thanks for inviting me for the conference. I was here last year, which I enjoyed very much, and I'm very glad to be here again today. So I have no conflict of interest. Okay, so just to go through a little bit of Singapore. Okay, so Singapore is smack right along the equator, and it is made up of various ethnic groups. We are mainly surrounded by the Malays and the Indonesians, but a large number of our population are actually ethnically Chinese. We have a smaller population of Malays as well as Indians. So our disease pattern is a little bit varied. And while we think that DVT risk in the Asians are actually lower, but we do have a fair amount of South Asians where their disease pattern is very similar to that of Caucasian. So what is in the Singapore context is that there is a myth that DVT is actually not common in the Asian population and is considered mainly a Western disease, leading to a lower clinical suspicion. But in actuality, it's actually increasing in number. And there was a paper done, it's quite a while ago, about 20 years ago, that shows that there is quite a high incidence of DVT in our population, and especially as Singapore is a very advanced society in that sense. Our population is rapidly aging, and as with more intervention by the orthopedic surgeons, as well as a higher cancer risk in the older generation, it is no longer a rare disease. In Singapore, you cannot talk anything except money. Okay, so in Singapore, money is very, very important. We have both a government framework where they have to pay for healthcare, but there's also a very big substantial area where it is actually private insurance. And as we know that with a rapidly aging population, we have a silver tsunami, which means that more of us are getting silver hair and gray hair, as you can expect. And the government has even set up an agency for cost effectiveness to tell us what are the devices that can be used and cannot be used. And of course, we know that the main driver of cost is, of course, devices as well as the length of stay in a hospital. So in fact, this is something that's very recent. It came out in just 2 weeks ago, and it is basically how the private insurance companies are trying to crack down on the cost of healthcare, and they are actually increasing the deductibles. And if you are familiar, that means that more out-of-pocket payments. So because of that, we are very, very cognizant about costs in Singapore. And as part of that, DVT is a management of DVT is actually a very closely related and multidisciplinary approach between different subspecialties, including hematology, IR, vascular surgeons. And the goal, of course, is to get these patients to the cath lab as soon as possible to treat them for life-threatening DVT. The future direction in Singapore, we are seeing more and more patients getting diagnosed with non-thrombotic iliac disease lesions and chronic venous insufficiency as well. So more and more patients are getting venous stenting, and the aim is, of course, to reduce the PTS. So what's the previous standard that Singapore is using? Up to about 10, 15 years ago, catheter-directed thrombolysis was still the gold standard at that time. But we know that these patients need to be followed up, and they need to come back down for frequent check angiograms, and they need to be monitored in the ICU as well. And they carry a major risk. And because of that, remember what I mentioned about the fact that length of stay will determine the cost of healthcare. So this is slowly getting replaced by newer devices. And in Singapore, actually, we are very lucky to be able to play with a lot of new toys. We are very lucky that the vendors are very willing to help us in starting services as well as to give us toys to play. The data shows that in Singapore, in a very recent paper, that if a patient is just being treated with anticoagulation alone, the result for the PTS is not as good if the patient actually goes towards endovascular therapy. And that's the reason why in the last 10 years or so, there is a very strong push for us to go towards the intervention route. So we are very fortunate to have the penumbra system in Singapore. The main thing is that because these patients are treated with mainly suction, and there's no need for any anticoagulation or any lysis. This patient actually doesn't need to go be monitored in the ICU, and potentially they can have a shortened time in the hospital, hence helping to reduce the cost as well. Now, of course, it's very fortunate that we have a computer-assisted system where the amount of blood loss is actually reduced. So just a case example, this is an 80-year-old Indonesian lady which presented with left lower limb swelling, and a bunch of tests was performed for the patient as per usual. And you can see that this patient has very extensive DVT all the way from the groin, all the way down to below the knee. And the culprit lesion is because of the classical May-Turner. So what's very satisfying about the penumbra system and the suctioning device is that with a bit of contrast, if you line the clots with contrast, you can actually see the clots getting sucked away. And for us, interventionists, it's always very satisfying to see this because you're actually seeing something that's working in real time. So after that, after going a few rounds, you can see there's a re-established antegrade flow, and of course, the patient ends up with a stenting as per usual for a May-Turner's. And the vendors love to show us this, and we love to show this to the patient because it shows after spending so much money, at least they have something to show for it. Thank you for your attention.
Thank you so much.
Thank you.
And so you see, so you use Indigo, Bolt. What kind of device do you use in this indication?
Okay, so it really depends on the size of the vessel. So if it's able to take a 12-inch sheath, of course, you try to use the bigger one, and it's a bit more steerable as well. So that's what we like to use. That's the main one that we use. Sometimes, depending if it's a smaller size, then we had to use the 7.
Okay.
Yeah.
Another question, Wouter?
Is this an expensive device in Singapore?
Yes, everything in Singapore is expensive.
So,
I mean, joke aside, it is an expensive device because Singapore is considered a first world country in that sense. So the vendors, there's no reason for them to reduce the cost down. But in healthcare costs in Singapore, a lot of it is driven by ICU stay. So if we can get this patient out of the hospital as quick as possible, then overall, the results are good, and yet the patient doesn't need to stay in the hospital long enough. And basically, if you look at the cost analysis, it's more or less quite similar. That's in the private sector.
Any question?
No?
No.
So,
Oh, yes,
thank
we
you
have a
very-
question here.
Is there? Oh, sorry. Especially completely in the back, in the corner, so that we need to run a lot. No, it's very good.
Are you Claude Cancun?
Yes.
Hello, sorry, just a question.
Yes.
How is the regulatory landscape in Singapore? Is it like straightforward as in New Zealand, or it's a bit more complex for doing clinical research? I mean,
So the regulatory framework in Singapore is that they have one where you go through something like the FDA, where you have to show proof that whatever you want to bring in works. But we also know that in the Singapore context, it's impossible. They don't have the manpower nor the ability to test everything that the vendors want to bring in. So we do sign, not in this case, but in some of the newer devices that we want to bring into use, we had to sign the undertaking that the doctor is responsible for it. And that is a renewal every 6 months or so. So there is a regulatory framework for us to bring in new devices.
Another question?
Yeah. Good.
No.
You are fine?
Thank you
Thank
very
you
much.
so
Thank
much.
you. Thank you.
Thank you so much for sharing. It's my pleasure now to call Dr. Obara. A few years ago, during JET, in Osaka, I guess, I had a pretty good debate with a colleague of Dr. Obara, Dr. Oki, about CFA. I am still wondering what is, the indication of open endo. So what is the management of CFA in Japan? So thank you for coming and to share.
Good afternoon, everyone. My name is Hideki Obara from the Keio University, Tokyo, Japan. So today I'd like to talk about the Japanese surgical view on the CFA treatment. So this is the COI. So as you know well, we know well, so the trend for the common femoral artery lesions throughout endovascular treatment largely accelerated by the TECO trial. So in this RCT, Dr. Gericke showed that the surgery and endovascular treatment stenting had a similar patency rate. But the surgery had a significantly higher rate of the complication rate at 26% than the EBT. So he concluded that EBT is safer. So, but in Japan, our view is quite different. So we conducted a cauliflower study, which is a large-scale Japanese retrospective study. The results are clear. The primary patency of the TEA was significantly higher than the EVT, and the complication rate of the TEA is only 5.7%, which is much less than that of the TECO trial, 26%. So in Japan, we argue that the surgery is always better than EVT. But Dr. Grepik challenged me that, okay, so Dr. Obara, so the cauliflower is a retrospective. Show me RCT data. He has a point. So we haven't conducted an RCT yet, but today I will present the 12-month prospective results of the common femoral artery thromboendarterectomy with bovine pericardium patch angioplasty, freshly analyzed just last week. So our aim is to show that we can achieve better CFA-TEA results than TECO trial. So that we believe that the Japanese patients have a lower BMI and a lower surgical site infection risk. And the patch angioplasty should improve the outcomes. So our study is a single prospective multi-center observational study conducted at the 9 hospitals of our Keio Vascular group. That we enrolled 150 patients, all underwent CFA-TEA with bovine patch plasty. So the primary endpoint was the 30-day perioperative wound complication rate. And here are the patient's characteristics. The mean age was 75 years old. And the patient's comorbidities are compatible with the previous study, other than the patient's late on dialysis. So, but the region has a very complex. The severe CFA stenosis of over 90% are present in 80% of patients, and severe calcification in 76.5% of patients. Even with this severity and complexity, the technical success rate is 100%. So here are the post-operative outcomes. The ABI improved significantly from the 0.39 to the 0.83. So for primary endpoint, the wound complication was 9.5%. So this is significantly lower than that of the TECO trial, 26%. So our TA with bovine patchplasty is safer. So in this our study, the 1-year primary patency was excellent as a 93%, and freedom from TLR was 95%, and amputation-free survival was 90%, and overall survival was 91%. So our study confirms that the CFA-TA with patch angioplasty using the bovine pericardium in Japan results in significantly fewer perioperative wound complications than the TECO trial. So I'd like to say that in Japan, surgery is clearly better, and the surgery never left. Merci de votre attention. Thank you very much.
Perfect, perfect. Thank you very much for this. Nice. Jan, I was completely impressed. Mean body mass index 22.
But
if I do this in Belgium, mean body mass index is 32.
Japanese vascular surgeons are also very polite because it's perhaps not just due to the patient. This good result also could be due to the quality of the vascular surgeon in Japan in comparison to the French vascular surgeon. About the cauliflower study, I don't remember. I was not sure, but what was the routine endovascular treatment in the endovascular group? It was based on angioplasty, stenting, DCB. Do you have
the target basis of
in the cauliflower data? What about
cauliflower data?
Yeah.
The common femoral artery.
What
so
about the endovascular technique?
So there are so many cardiologists doing the CFA treatment because of you. So we gather the retrospective data. So gathered all kinds of the endovascular treatment for the CFA and the surgery. That's the retrospective.
But was it stenting or ballooning?
So it's including all of them. So maybe the stenting it's about the 40% or something, right? So
that's the mistake.
No. So I know that the TECO trials is the stenting. So, yes. But in Japan, so stenting in the CFA area is not covered by the health insurance. So that's a kind of problem. So I understand that there is something, the difference between the TECO trial and our study. So.
Very good point.
According to metadata, also you release as this data, Kun.
Very good point.
We didn't have so good results with angioplasty at the CFA level.
No. In my hands, and by the way, also if you do an overview, not only of the Japanese literature, but all the literature, you see that the vast majority of the trials only using angioplasty with POBA or with DCB or whatever, they don't work. If you compare this with or stenting or debulking with DCB, then it's another story.
Yeah. Is the bovine patch is a usual treatment, or do you use a bypass in some case, vein patch, prosthetic patch?
So this kind of bovine patch is covered health insurance just 5 years ago. So that's the reason why we did to see the results of the bovine patch. So basically, we prefer to use the bovine patch right now. So in Japan.
Okay, and why? What is the reason to use a bovine patch instead of vein or prosthetic?
So this study, including 40% of CLTI patients, so this kind of patient is going to have something, a CLTI in the future. So we preserve the autograft vein.
Got it. Okay.
So I never saw such a sportive person to make a study to make Guvek happy. It's very nice from you. But in the study we do perform a controlled study, we also do angiogram after the plasty of the groin. And sometimes we see what we don't expect. Some dissection, severe dissection, occlusion. Did you measure that too?
So basically, in the protocol, we try to do the angiogram. So because in this study, the 80% have the additional treatment for the proximal or the distal using AVT or something, right? So maybe over the 80% have the angiogram after the procedure.
Thank you very much, Dr. Rivera. Great work.
Thank you.
Thank you.
Thank you.
So now we move all the way to Kuala Lumpur, to Malaysia. Dr. Zaharuddin, you're going to tell us something about your country and more specifically the management of acute limb ischemia. Please.
Okay, thanks everyone. Thanks organizing committee and also Jan and Ken for having me here. Definitely, I think I would love to share with audience about the management of acute limb ischemia in Malaysia. And for everyone who never been to Malaysia, basically, yeah, this is my disclosure. This basically, you take about 13 hours flight from the one end to another end. So in order to reach Paris. So yeah, definitely I'm happy to share with everyone about how we're dealing with the disease of acute limb ischemia in Malaysia. So roughly in Malaysia, we have about 45 million populations. And acute limb ischemia is the second commonest vascular emergency after the vascular trauma. And in terms of the national data, we don't really have very specific about the ALI, but majority is all the institutional based, either case series or case report. And in terms of the cause of the acute limb ischemia, still embolic, even though with the improvement of the cardiac intervention for the AF, we still the dominant, but there is a rising of the, can see in terms of the trend of the patient who are having a thrombogenic cause due to underlying of PVDs. And at the same time, because of the COVID pandemic, we can start seeing the more and more cases of acute limb. And in terms of the surgical treatment, still the surgical embolectomy is a mainstay of treatment because of the cause and issue. But we're still seeing the rising trend of the endovascular first in treating acute limb ischemia, especially with CDT, even though there's an issue of the thrombolysis, the availability in my country. But the new trend like a thrombectomy with CAVT, penumbra, we start seeing the more and more endovascular space being treated. And I think I won't go into the detail. I think Jan and have a penumbra event snapshot that whether there is a role of endovascular or shifting from surgical to endovascular first approach. I think the guideline have shown. I think there is a benefit either it's combined or single therapy in dealing with acute limb ischemia, depending on the Rutherford classifications. So in terms of option in Malaysia, yes, we have everything. But the thing is cost and also whether patient affordability will give us the option whether what we can do to the patients. For, I think the slide study give the ideas, what option that we definitely, and we can see even though with the old Indigo system, the result is fairly good, and definitely we're looking into more like Indian trial and also the Stride 2 later on in the futures. In terms of my center, so basically we are adopted the endovascular first in treating patients with ALI, DVT, and also thrombus AVF. And these are the single operator, and been introduced since June 2023 until 2025, 215 patients treated with penumbra system. So these are including lightning, bolt, and also flash catheters. So these are basically distribution of patients. We can see the 85 patients were treated with LI, and also we are treating also patients with the thrombus stent, especially aortic and also the peripheral stents. And most of the patients treated completely with the clot clearance, and we use the TP classifications to see whether we get good clot clearance and also the flows. 85% was achieved the TP3, and only 15% were TP2 that require some adjunct interventions. So now we're moving to some of the cases. I think Giovanni and Luca have shown about the patient who are simple and complex. So I would like to share with the audience some of the cases who are treated in my centers. So they are okay with the SFA occlusion. We use in this case, I use a bolt 7, a single pass. You can see I don't like use separator. Most of my cases, I like see there's a wire inside too, and you can see with the single pass, you can get good clearance with the TP3, achieved in this case. Then some of the patients that we treated in the BTK lesion who are coming with very bad acute limb, then we can push even up to the crossing the ankle, especially the availability of the CAT6X. And these are the post-bolt 7 angiogram show there's good flows. And sometimes we're dealing also in the patient with a chronic component. You can see the calcification, in this case, a flush occlusion. We have to use a retrograde, and you can see there's a calcium is there. And we managed to cross the lesion, and then we snare. And then I think with that, in this case, I use a bolt 12. You can see that with the body floss method, we're able to just push the catheter down to the segment, and then you can see after a single pass, you can see a good clearance in this case. And sometimes, in this case, a patient who are from the neighboring country was referred to my center because of the thrombosed bilateral iliac kissing stent. In this case, I use a bolt 7 to get good clearance. I come from the percutaneous auxiliary approach, and we get the first pass on the right side and also second pass on the other sides. And then can see post-bolt, you can get good flows and good restoration of the flows in the occluded stent previously. I think that Giovanni have shown a case of the thrombosed iliac limb. We also have a similar issue. In this case, very unfortunate, the patient was treated with the endoconduit for the EVA with IBDs, but the thing is, patient developed upper GI bleed, was discontinued the APT, and then the limb was thrombosed. And then this patient, I used a body floss method with the percutaneous auxiliary approach, and then we just passed the catheter, both 12 in this case, and then you can see I use body floss techniques. In this case, you can see after a single pass, you can see there's a good flows on the system. And then at the same time, we're not only dealing with the lower limb, we're also dealing with the upper limb. In this case, you can see there's a sluggish flow of the radial. We use a bolt 7. These are the earlier patient who are upper limb. Then you can see the after restoration, nice flow in the upper limb. You even see there's a AVM of the wrist area. And as we're getting familiar with the catheters, we even pushing the boundary. We even treated in patient with a pediatric case with the occlusion post-intervention due to coarctations. And then in this case, was published. And then we share there's good flows after using the, in this case, we use a lightning 7 to get the clots out. And ladies and gentlemen, as a conclusion, I think endovascular first have been discussed. Definitely is a reliable method in treating ALI, but we need more clinical evidence. With the availability of the penumbra CAVT, I think this is one of the modalities that we apply in treating patients with ALI. Have shown that a lot of the papers have seen there's a good result, and definitely these are most reliable method. But the thing is, cost is one of the limitations, especially in the Asia region. But then I think thank you again for your attentions.
Thank you very much. Great talk. So are there remarks or questions? So we know that, so amazing to see switch from surgery all the way to endo. Why particularly this device? We know that there are a lot of thrombectomy devices, atrial thrombectomy devices at the market. So why did you select specifically this one?
I think in my center, I think we were started with the endovascular first policy about 5 years ago. That time we don't even have the lightning. We started with Indigo, but that time we are comparing with the Rotaract, Aspirex, and also some other modalities. But the issue that I will see in my center, I'm not stated in general, but in my center there is a competitor who are coming with I think incomplete clot clearance due to, for example, like using the jet stream, and then there's an issue developed after using the angiojet because of the bleedings, and repeated procedures is sometimes in the private center is an issue for the patient because of the cost. Then I think we are doing an audit after we decided to see what are the options that we use out of these 3 methods. I think the one who will give a most good outcome of this initial paper about 60 patients, so which is a penumbra. That's why we start focusing on the penumbra itself.
And in your opinion, cost effective?
In terms of the overall, yeah, we have our own audit and compliance unit who are looking into the overall. We're not looking into the device per se. So yes, for the penumbra, the device is compared in terms of cost is more compared with other devices. But in terms of overall stay, we see there is a markedly reduced in terms of a hospital stay in the patient who are treated with penumbra, which is in my center. I think most of the patients was discharged on day 2. Only 1 or 2 patients were discharged after day 3 not because of the patient developed fasciotomy, but the thing is just because of some of the patients who are required on warfarin, and these are the cause of why this patient have to stay. But in general, I think because of that, I think we have decided to focus solely on the penumbra, and then I think definitely next year we will share with our regional levels in Asia that we have our own data about 2 years of patients who are treated with the endovascular first method with the penumbra.
And you think with this data you can convince the Malaysian healthcare providers, payers, to get some reimbursement, or what do you think?
in Malaysia, we don't have a reimbursement system. So basically, we have a private setup, and also the either each patient have to pay under their own pockets. So, but I think with the availability of the data that I have, even though small data, we managed to convince our own population that where they are willing to pay for this kind of the devices, because of the shorter hospital stay is better than more, and in terms of overall cost, definitely is better compared with other devices at this moment.
Totally agree. Yeah.
Okay.
Yeah.
Thank you so much for coming and for sharing with us.
Right.
No, we have a huge evolution, you know, not just for lower limb, but also for PE. And so I call Varinder Singh Bedi from New Delhi to share with us some insight about the treatment of PE in India.
Thank you very much for the opportunity. It's been a pleasure coming out here, and thanks for inviting me to the organizing committee. And I admire your energy, which is there. You've been going on for the last 2 days.
Almost empty.
Amazing.
Almost empty.
Amazing, amazing. So, to talk about pulmonary embolism, endovascular therapy in India, I have no disclosures. To look at the epidemiology of pulmonary embolism, the global burden is the third most common cause of cardiovascular death worldwide, and leading preventable cause of death in hospitalized patients, with an annual mortality in US was almost about 100,000 patients, deaths rather. In the Indian context, overall mortality is about 25.7% in the Indian cohort, and the massive PE mortality is almost 72.5%, which is very high. There's a critical need for awareness and specialized centers in India. When you look at the trends in VTE, the prevalence is expected to double by 2015. So it's a significant burden. So the goal of PE management is prevention of death from the current embolic event, to reduce the chance of recurrent embolic events, and to minimize long-term morbidity due to the event. The various cornerstones of treatment so far have been using unfractionated heparin, low molecular weight heparin, fibrinolysis, catheter-directed thrombolysis, which was again the mainstay of treatment for a long time, aspiration thrombectomy, surgical thrombectomy, and of course in certain patients to use IVC filters. And of course, as I mentioned, anticoagulation and thrombolytics are the mainstay of treatment. So how to choose the patient for catheter-directed intervention? One is, of course, to look at the resources that you have, the operator experience, the patient stability, the bleeding risk, and the thrombus distribution, and the vascular access. So in favor of the lytic therapy, of course, is widely available, minimum learning curve, and low cost and moderate clinical stability, and favorable bleeding risk for RTPA and any thrombus distribution. In favor of mechanical thrombectomy, hemodynamic deterioration, even the need for ECMO, so unstable patients can also be taken up. And bleeding risk is again not there at all. High thrombus burden can be removed. And a proximal thrombus more than 4 millimeters of femoral or jugular access is required. So the latest trial which has come out this year is the STORM-PE trial. I think this is something which has really changed the paradigms in terms of looking at CAVT, the computer-assisted vacuum thrombectomy, plus anticoagulation. I think that has made a lot of difference. When you look at the primary endpoints, there's a significant reduction in the RV-LV reduction, expanded RV-LV, 48 hours to RV-LV reduction. And again, the safety endpoints and all are excellent for that matter, and functional endpoints are also very good, very remarkable with this one. Again, the flash registry also pointed out at similar kind of results, which was there to show you a few cases. A case of bilateral pulmonary thromboembolism, 53 years old male, diabetic hypertensive, with dyspnea associated with fever and cough for 1 week. And SpO2, he was requiring 6 liters of oxygen. And of course, the PA pressures were elevated very highly. IVC was dilated. Bilateral segmental thrombolysis, thrombus was there. So here we did a venography followed by thrombolysis, as you can see out here. This is the pre-CDT movement. And then after that, once we cleared out, we were able to clear out the complete clot out here. This was, with thrombolysis and all. This is what we did in this particular patient. The second case was again a 27-year-old male, no comorbidities, and pain and swelling of left lower limb with breathlessness. And again, extensive thrombus in the lower limb, and CT pulmonary angio also showed extensive thrombus. As you can see, the left pulmonary artery is practically not visualized out here. And this is where we use the CAT16 penumbra-assisted thrombosuction of the lower limb via the left popliteal, and bilateral pulmonary artery thrombectomy done from the right CFE. So first went to the right, then we went to the left. And then you can see all this clot coming into the chamber out there. And this is something which looks very, very rewarding at that particular time, because you can see all the clots coming out there. And then after that, you see an excellent result out here. And this is what really comes out. A lot of acute as well as a chronic thrombus also comes out most of the times. Another 80 years old female, right iliofemoral chronic DVT with fever and dyspnea and dry cough for 1 week, again on oxygen. And again, PA pressures are 65 millimeters out here, pre-CAVT. This is what the thing was. So you can see that there's no thrombus, there's no circulation distally into the pulmonary artery on the left side. And this is what happens after you clear out the thrombus from here. And this is what comes out after that. So a lot of acute thrombus which came out in this lady, and she's about 2 years down the line, and she's doing very well. So when you look at our institutional data, comprehensive retrospective analysis of 36 patients we managed over the years, and it's a good program. And now with the use of percutaneous thrombectomy devices in the last couple of years, this has been a very handy tool in improving the outcome out here. And to look at the key finding, 36 cases with mean age of 45.7 years. So we see a much younger subset of patients out here. And CDT remains the workhorse, now 61% with growing adoption of mechanical thrombectomy. In the last couple of years, we've changed our strategies, doing much more of mechanical thrombectomy as compared to CDT. And again, the key findings out here, a lot of these patients have PT along with DVT and all also. And we see much more of males out here and much more of the younger population. It's not that we are not seeing only, and this is just to show our DVT association in PTE cases. You can see a lot of these patients had PTE. And thrombolytic dosage and all, we found an average of about 40 to 60 milligram of lysis was required. And again, now you see the pie chart out here. Now the CAT16 has probably taken over a lot of it, and all these other cases were probably done much before that. So to look at the summary, endovascular therapy is revolutionizing the PE management. Level 1 evidence now supports mechanical thrombectomy, and the PERT program, of course, is going to be very useful. And in Indian context, significant disease burden, the younger patient population, emerging infrastructure in select centers, and success stories from pioneering institutions. And there's an urgent need for expansion and accessibility. And to take home points, basically PE is under-recognized but highly lethal in India. Mechanical thrombectomy is much more superior to catheter-directed thrombolysis and anticoagulation alone. PERT reduces mortality and should be standard of care, and follow-up essential to detect CTB. Thank you so much.
Fantastic, thank you. Great talk. Questions?
I always wondering, when you have embolism, you should have some acute staff, some subacute chronic staff.
Yes.
Does it so much effective according to, for example, with some chronic clot?
Yeah, we do find that chronic clots also come out very well with this. That is something which is remarkable. In fact, in most of the patients, you always found that there's almost some element of chronic component also, the gray thrombus that you see many a times. And this is something I would say that almost about 50% of the patients have that.
And so finally, you don't care if it's acute staph, acute clot, or chronic clot?
So no, most of these patients present with acute and chronic. So a lot of them basically don't really have a history of an old pulmonary embolism, but when you take out these clots and all, then you get a history, and then you find that probably he had some minor attack of DVT earlier and never really bothered about that.
Thank you.
Yeah. Fantastic. A question?
Nice presentation, thank you.
Thank you.
Do you use personally long sheath when you do this?
I think, yeah, we do always use a long sheath in that one. We use a 16 French long sheath, about 45 centimeters long. And along with that, we use the catheter. And we have, from Penumbra, they have a long catheter also, which is 125 centimeters long. And that helps you navigating, because many a times what happens is when you're taking your catheter up, it's a stiff catheter. So pushing in the catheter specifically into the left pulmonary artery or the right at many times becomes a little challenge. So what you do is you use the long catheter with a thermo wire, try to get across, and then after that you exchange it with a stiff wire, and then get your catheter across.
Okay, perfect. Thank you very much.
Thank you.
So now we go back to Singapore again, and it's my pleasure to invite Dr. Chung, a good friend, to the podium, and tell us something about a real-life experience with the Ranger DCB in Singapore. Please.
Just a quick call to all the speakers. Just after the session, we will make a photo with all the speakers together on the podium. So please stay until the end of the session. Go ahead.
Thank
Can we have the microphone of Dr. Chung? Or is there a technical issue? Can you test it again?
I think it's past 6 o'clock. Okay.
Perfect.
Good evening, Chairman. Thanks to Koen and Jan for my first time here at PVI. I'm glad to be here to share with you the outcomes of the Ranger DCB in Singapore. Note relevant disclosures. We participate in the Vascular Quality Initiative, which is the US registry, and we're the first and only non-North American site. We look at the total number of Ranger cases. We take away those which have concomitant treatment, other DCBs, and there are 80 patients left over with 82 limbs for analysis of BTK. These are the relevant demographics. You can see 68 years of age, BMI, male preponderance, and most of them ambulatory. The comorbidities are shown over here, and I just wanted to point out two in particular. Diabetes is at 86.3%, so very high rates of diabetes in Singapore, likely due to genetics, diet, lack of exercise. End-stage renal failure rate is 36% here, so this kind of population with high diabetes and end-stage renal failure represents the worst of the cohorts for these patients. The only silver lining, below smoking, current smokers, only 15% of these population. If you look at preoperative medications, they do relatively well, 78% with antiplatelets, statins at 85%, ACE-ARB at 42.5%. Certainly we could do better there. In terms of surgical history, prior PVI on that index limb is about 41%, and already high risk because they have had prior minor amputations at 26.8%. For leg symptoms, these are not claudicants. In general, they are CLTI disease with ulcer, non-healing amputation, or both in more than 90% of the patients. That's why there's so much BTK disease in these 82 legs. This complex picture looks at the Wi-Fi classification of wound, ischemia, and foot infection on the left side, and the clinical stage translates to the moderate and high risk you can see on the right side of 66%. With that, these are the distribution of the vessels treated. You can see the AT is the most common vessel treated at 43%, and the rest are seen over here. Lesion characteristics, about 30% are recurrent lesions. De novo is about 70%, mostly class C and D lesions, and calcification moderate and severe. The median occlusion length in our population is 15 centimeters, so quite real world, and despite that, the technical success acceptable at 96%. These are some of the survival curves. You can see freedom from CDTLR, 6 months, 94.3%, 12 months, 91.8%. So quite good when you consider the Wi-Fi score predicts moderate to high risk of amputation. Freedom from major amputation shown over here, 6 months, 95%, 12 months, sustained at 95%, may be representing the sustained drug effect of the Ranger DCB in inhibiting the restenosis. Freedom from major amputation, I split the curves into those with diabetes and those with end-stage renal failure because we know they are the worst performers. As you can see, those with renal failure, 6 months, 89.8%, and 12 months, 89.8%, which is worse than the diabetes-only group. So despite that, I think it's a relatively good outcome in the 36% of patients that are dependent on dialysis. This is the overall survival. This is a tough group of patients. We know they have a 25% risk of mortality from the many, many trials that have gone before this. And the overall survival at 12 months here is 83.3%. So perhaps we need to do better with their medical therapy in this group of patients. The overall amputation-free survival, what we'd like to see in this group of patients, predictor of patency, you can see 6 months, 88.7%, and at 12 months, 79.6%. So I think it's quite respectable, can be improved. These long lesions at 15 centimeters in the BTK segment are difficult to treat in this group of patients. So with that, I'd like to thank you for your attention.
Thank you very much, Dr. Chung. Impressive results with the low-dose paclitaxel balloon, the Ranger. Great. Questions? Remarks? Yes, please.
Yes, very impressive presentation. I just wondered, do you have any vessel preparation before the application of Ranger, something like debulking?
Thank you for the question. I think vessel preparation we recognize is very important in all kinds of lesions and definitely in the BTK lesion as well. First step is crossing. We have a 30% retrograde risk for this group of patients. In terms of debulking, we do less of the atherectomy. We don't have a separate CPT code, unlike in the US for debulking. So we have less incentive maybe to do that. We tend to do POBA, generally 2 or 3 minutes POBA, and nowadays a lot of non-compliant balloon use in this segment for vessel preparation. We think that that gives good preparation for this group. We have the rest of the atherectomy devices, but we don't use it as much because we're not sure entirely if it adds too much value in all of the patients. And then on top of that, we put the Ranger. We have no restriction in the use of the particular balloon in the BTK segment. Patient does have to pay a certain amount for this. And we are conscious of the slow flow phenomenon that sometimes happen with this, but as you mentioned already, it's 2 micrograms, so it's a lower dose. So less of that, and in general, a relatively good result.
In France, but it comes from China, we just have Acotec DCB. It's from China. So do you have any experience? It just reimbursed since 2 weeks. So it's new. Do you have any experience about this balloon, or could you share?
I think Boston Scientific and Ecotech have a partnership, as you know. So in Singapore, we use the Ranger mainly. We use the Ecotech for the large sizes and the long lesion lengths. So we have some experience with those. I think our Chinese counterparts have a lot more experience with the Ecotech balloon, but I think they are pretty similar. And I think that the risk of mortality, as Katsanos pointed out, is really not shown in our data set.
We have Professor Wegu here, so it's Chinese guy from Shanghai. So could you tell us more about the use of Acotec?
Yes, a lot of the patients we use the Acotec drug balloons for treatment the lesion.
Is it similar to Ranger?
Yes, I think because in China we have a small experience for use the Ranger, but a lot of the patients use the Acotec drug balloon.
Thank you.
Thank you very much.
Thank you.
Chung. Thank you. So
your turn. So we shift now from below the knee to the aortic part and mostly thoracic, because we are going to know more about the management of aortic dissection in China. Thank you so much.
Thank you, Yuan. Good evening, ladies and gentlemen, distinguished moderates and guests. I'm Dr. Fu from Shanghai, China. It's my pleasure, it's my great honor to be invited to attend this conference. So my topic is the aortic dissections management in China, a journey from the open and endovascular innovation. I have no disclosure. This is the current situation of the aortic dissection in China. We comparing the China with the Western country of the aortic dissection epidemiology. There are two differences. The first one is the incidence status. China has 3.6 10,000 populations per year, but Western countries has 1.8 populations years. The second one is the age disparity. Chinese median age of the aortic dissection is 58 years, but Western countries' median age of the aortic dissection is 63 years. So we, over 20 years, aortic dissection spectrums should treat us in China. The one is the incidence rate is increasing. The second one is the marked younger treaties. And the third one is the uncontrolled hypertension. So aortic surgeries volumes in China have seen remarkable growth over the past decade. From the 2017 to 2024, procedures like TIWA, EVA, bento, and the total aortic arch replacement have all seen dramatic increases. So some even more than the doubling. This sharp rise in surgical demand signal the growing burdens of the aortic diseases in our country. This is the two refined classifications of the aortic dissection in China. The one is the Swiss classifications of the type A aortic dissection. The other is the 301 hospital classifications of the type B dissection. So we have two key open surgeries achievements by Chinese scholars. The one is the selective cerebral perfusion from the right axillary arteries cannulation. The clinical applications in 1995, the incidence of the central nervous system's complications decreased from the 18% to 5%. The advantage of this technique should shorten the hospital stay of the patients. A routine method for pulmonary bypass and cerebral protections in aortic arch surgery. The other is the Swiss procedures for the open surgery of the type A dissections. It has become the standard procedures for the type A aortic dissection in China. The surgical mortality rate has dropped to below 5%. Fourth Roman remodeling rate has increased from the previous 18% to 40% to over the 95%. The reoperation rate has decreased from the 13% to below the 10%. This is the summarized of the development and the status of the aortic endovascular therapy in China. From the 1997, the TIVA and the EVA procedure introduced to China. Just only a few medical centers can perform these procedures. But we look at the 2024, more than the 600 centers offer the endovascular surgeries, annual TIVA procedures more than 13,000 cases. So currently status of the aortic endovascular repair in China should steady growth and cases spread across the hospitals, but complex the ones in key centers. Existence the challenges include the development of the novel devices and supporting the technologies are slowly. And aortic anatomy via rotations, restricted endovascular applications, and unmet clinical demand. This is summarized the Chinese experience in endovascular repair of the complex aortic dissection. The one is the pirate stand technology, technique in the total endovascular therapy. The advantage should open advantage of open operations is relatively simple and satisfactory of the standard patency rate. But this advantage is the high endoleak risk. The main advantage of the parallel support technique lies in the fact that all the products used are already on the Chinese marketing. But the risk of the internal leakage is relatively high. So if there are other available strangers, it is not recommended to the use of the parallel stand technique as a routine approach. The second one is the fenestrate stand techniques in the total endovascular therapy. So it better align with the branch vessels, which is the key for keeping blood flow to the vessel or cerebral arteries. It is the immediate and flexible, no waiting for the custom-made stand graft, so we can adapt to the patient's unique anatomy during the vascular surgeries. So it has drawback to the complex cases bring the higher stroke and vascular injury risks. It may damage to original stand graft, lowering the durability, and it need a vascular surgeon will be higher skills and a long operating and stand modification time also rise the infection risk. So the third one is the branched standard techniques in total endovascular therapy. In China, customized standard grafts are still in the development stage. The cost of the 4 customized standard grafts is relatively high, and there are currently no available products on the Chinese market. So they cannot completely replace the PMAC technique. In China, patients with the urgent need currently give the priority to the use of the sheath of the stents. This is the core innovative aortic device led by the Chinese expert. Chinese scholars have also conducted extensive research from the perspective of the intracardiac device, aimed to solve the problems of the total endovascular repair of the aorta. So this is the waveflow arch is suitable design. Waveflow arch designs by the Dr. Guo Wei's, just suitable for the ascending and arch lesions, and fibrous stent graft and a few series designed by myself, just suitable for the type B aortic dissection. So the conclusion for these slides: advanced aortic dissection treatment in China have a characteristic factors. The one is the paradigm shift from the open surgery to the total endovascular therapy. The Chinese aortic dissection treatment is undergoing a landmark transformation from the traditional open surgery to the minimally invasive total endovascular therapy. The second one is the innovation of the TIWA procedure technologies is the continuous technique upgrade. The co-endovascular techniques, TIWA procedure has undergoing a clear interactive innovations to meet increasingly complex clinical needs. The third one is the technological empowerment is AI and imaging enhanced vascular surgery's confidence. Emerging technologies provide great support for the vascular surgeons, make the complex endovascular procedures more conveniently and calm. So last one is the future perspectives is innovation driving the total endovascular area. With the continuous domestic device innovation, China is poised to enter the fully endovascular area for the aortic dissection treatment. Thank you for your attention.
Fantastic talk. Thank you very much. So questions in the audience? So if you are looking now in China, how many centers are really performing this kind of high-level total endovascular therapies? So I'm not speaking about open surgery, but this high-level total endovascular therapy. How many centers do you think in China offer this?
In China, we have performed open surgery to repair the complex aortic dissection is just maybe just less than 15 centers. But if we use the endovascular therapy to repair the complex aortic dissection, maybe more than 100 centers.
More than 100 centers can offer this. And what is, like in your center, what is the caseload per year?
Per year, in my center, we have performed the complex aortic dissection or aneurysms, more than 100 cases per year.
Unbelievable, yeah. Very crazy experience you need to have. There are not a lot of centers in Europe reaching this amount of experience. Fantastic. No more questions from my side?
Yes, last question. Last question, my God.
I moved. Hello. I have a question, actually. Are in China available custom-made devices from foreigner manufacturers, so not Chinese?
In China, we have no available custom-made devices. So we just use the PMAC technique to treat the complex aortic dissection.
Koen, it's time for a great photo, no?
Yes, I'm sure.
Yes,
great
everybody
photo.
wants this photo.
Thank you.